frequently later because I personally want to listen more, because these are precious for me too, to listen again and again about how did you invent TFP. So I may need to summarize what you have just said to the audience. I think that TFP's values is that TFP work with patients' identity diffusion, which is the roots of all personality disorder. And then we try to understand patients one by one, day by day, to offer the roles that the patient play and the therapist play, and the role changing, and what the patient really is seeking for. We call it the hidden maybe pairs that the patient actually is longing for. These are the strategies and techniques about TFP. If the audience is interested, maybe they can read Kernberg's books and other TFP handbooks. That would be very helpful to understand more. But I think TFP's unique values is also based on the integration of the patient's self and others' image. Yeah, so I think, Kernberg, you're telling us that what TFP therapists done is really based on the structure and the research of TFP. So it is really trustworthy to some extent. And as a therapist, I have really found it helpful for me to working in the structure Dr. Kernberg built very, very early years in his life till now, which is 2022. So it's amazing. It's amazing. So I will continue to ask you more questions, considering of the time. I think now you have a lot of research paper on how effective TFP is. And for me, in addition of learning TFP, I also learned the third generation CBT, such as mindfulness cognitive therapy and mindful self-compassion. Both are evidence-based psychotherapies. I noticed that different therapeutic approach seems to have differences, changing maybe mechanism and approach, but there are some common factors. It's just like chiseling the well of mind from different angles, but finally take a ladle of the same spring. So the next question is relating to, what do you think is the ultimate nature of spring, of all the therapeutic approach that really help our patients the most? Yeah, so this is about the effective factors of TFP, and what as psychotherapists, what are the factors that really can help patients? Maybe, yeah, not so much related to the strategy or techniques of TFP, but about the effective factors. Yeah.
There are several alternative treatments for personality disorders. You mentioned some of them: DBT, dialectic behavior therapy, mentalization-based therapy, good psychiatric management, frame-based psychotherapy, cognitive psychotherapy. Those are cognitive behavioral therapies, and they are, from the analytic side, there are other treatments too: psychoanalysis, expressive supportive psychoanalytic psychotherapy, supportive psychotherapy, brief psychoanalytic psychotherapy. Several of these treatments are effective in helping severe personality disorders. We have evidence that DBT, mentalization-based therapy, supportive therapy, transference-focused psychotherapy are all effective, not with all patients, all the treatments have certain limits. Not everybody can be improved by any or all of them. So some patients can be improved by some by others. And unfortunately, we have very little research comparing the treatments to each other. Usually the research is between treatment as usual and the specific approach that you are studying. There are few studies that compare the various specific approaches. So we have to use clinical criteria for individual cases to decide what would be the best. I have to make these decisions every week as I go and see patients in our personality disorders unit. And I use, as my most important judgment, I use the question whether the patient has some isolated, some specific symptoms that can be treated with cognitive behavioral approaches, or if the patient's entire life is in a chaos. When the entire life is in a chaos, it's preferable to use a psychoanalytic approach such as TFP. If there are concrete symptoms of a specific kind, I would first use a cognitive behavior therapy. So that is a practical way in which, of course, I'm simplifying. There are many other elements, but these are two important elements that make you decide what to use. Now, different treatments have different mechanisms of action, and there are some that are common, as you pointed out.
Yeah.
I think that the most important common element of all the treatments is the systematic, structured way of the treatment. The better the treatment is structured and each element fits into the total approach, the better the outcome. In contrast to vague ways of combining various techniques and without a clear integrated structural type. Second, the personality of the therapist is important in the sense that the therapist has to be intuitive, interested, have authentic warmth, and be able to tolerate his own aggressive tendencies, not to be contaminated by the aggression of the patient. So that a therapist with real interest and empathy and capacity to tolerate aggression and very bad and dangerous situation without denying their importance is helpful to the patient. The specific aspect of TFP is the analysis of the transference. That's why it's called transference-focused psychotherapy. In the analysis of the unconscious issues that emerge in the transference development. TFP is the only treatment other than psychoanalysis to do that systematically. And the difference with psychoanalysis is that psychoanalysis does not have the techniques for structuring the sessions and avoiding the acting out of severe aggressive developments. So psychoanalysis implies a patient with the identity integration and who behaves much more normal in the hours, so that one doesn't need to take strict measures as conditions for continuing the treatment. In psychoanalysis, the technique is technical neutrality. Technical neutrality bedeutet that technical neutrality signifies that the therapist does not enter into the transference development, stays as an outsider who observes and helps the patient observe what's going on. Psychoanalysis maintains strictly technical neutrality. Transference focused psychotherapy, in contrast, limits technical neutrality in that we control the patient's behavior that is dangerous to the treatment, to the patient, to the therapist. And whenever we intervene controlling the patient, we are disturbing the transference. We are creating an external reality that disturbs the repetition of what happened before. So what we have to do is whenever we control the patient, we then have to psychoanalytically interpret the reasons for which we had to intervene and eliminate the consequences of our interventions to keep the patient in the treatment. And so we return to a purely analytic atmosphere in which we can be technically neutral. That's one difference between psychoanalysis and transference-focused psychotherapy. The examination of unconscious meanings in the transference is what psychoanalysis and transference-focused psychotherapy have in common, and none other of the treatments has that approach. In other treatments, they study the patient's reaction, the patient's mindfulness, the patient's experience, but they don't study systematically the unconscious meaning of the interactions between patient and therapist that are being activated in the sessions.
Yes. So to summarize, there are three common things that actually we can offer help. The first is systematic and structured approach, which TFP also offers, but TFP offers more to integrate a person's identity diffusion, which is very unique, I think. And second is some elements of a good therapist relating to warmth, tolerance, be able to identify the truth instead of being defeated by patients' words. So these are also very important and relating to my next question. So maybe we will talk more about this part. And the second part, the third part, I think, is relating to how a good enough approach could prevent patients from acting out and drop off a therapy. So TFP offers more in this part, virus psychoanalytic work. So I think this question has been fully done. I think at first when I want to ask, because I see when a patient changes, it's not only about the approach we use, but it's very important that we use the right approach to the right patients. As what you have said, choose what is suitable for the patient. But I also feel that there must be something like the therapist interests on the patients. And this is my feelings that maybe the sincerity of the therapist, that the wish to really help patients can transfer through unconscious to the patient, that this person is really going to help me, not to harm me. Yeah. So I'm thinking in my work with you, I can feel this very clear, even as a supervisee, that I know that you really cares my patients very much. So I'm thinking maybe this is also a very important effective factors. I think this is based on love, maybe. Yeah. So I added a little bit. Would you agree, or would you want to say more relating to this?
I agree with what you're saying, and I would add that one technical approach that we find is very important is that at the beginning of the treatment, we ask the patient what he expects from treatment. What does the patient want? What does he honestly want from treatment? Because patients say, I'm coming because my mother sends me. I come to treatment because I want to learn more about myself. These are very vague statements. We want concretely, what is it that the patient thinks is wrong and wants to get changed through treatment? And he can have several goals. Now, at the same time, as we study the patient in great detail, we study his present life in greater detail than any other diagnostician. We have developed a method for diagnosis, which is called the structural interview, which studies the patient in great detail. We, in our mind, develop the objectives of the treatment that we have for the patient. I develop in my mind what I see the patient needs treatment for. So I have my objectives, and I ask the patient for his objectives. And we need to find at least one major objective common to patient and therapist. If it's one important major objective that is common to the list of the patient and the list of the therapist, the treatment will be going well, and you will be able to develop the right kind of strategy. If that is not so, it will not go. So this is one illustration of a technique that we have developed. And once we have the agreed upon overall objectives, then the therapist in each session is aware of what is going on with the patient right now and is aware of the long-range goals of the treatment. So we don't lose our objective, our long-range objective. It is so the treatment is structured also in the sense that is the long-range objectives are integrated into the daily work of the treatment.
Yeah, I totally agree, which are shared objectives, which can be long-term work together between patients and therapists.